Thank you so much. As I said earlier at the 4 o'clock presentation, I derive great satisfaction and pride from having a student as accomplished as Julie and all the things that she's done in her career. So maybe you don't know that Julie was one of my dissertation students, but we won't say how long ago that was. But what I'd like to do tonight is to single out some of the many advances that have occurred in the last 10 years in our understanding and management of ADHD. And I only have an hour, so I may have to skip over a few of these and not cover them in as much detail as I might ordinarily like to do. But nevertheless, I'm going to hit what I think are some of the major highlights of what's new about ADHD, this disorder that we've known about for over 100 years now. Before doing so, I am required at these public presentations to disclose my sources of support so that you can see whether I have any conflict of interest. And of course, I have many. But the most important one is to know that I do consult to every pharmaceutical company that has ADHD medications on the market. So there you have it. What I would like to do, of course, as I've said, is to talk with you about major advances in understanding nature and management, identifying the causes of ADHD. I also want to spend just a little bit of time on a theory of ADHD, of what may be going wrong under the surface of ADHD, because what we have right now is a description of someone's behavior. When we look at symptoms, when we use our DSM criteria for diagnosis, when we use rating scales in interviews, all we're doing is documenting what a person does. That's like saying that autistic children talk funny, flap their hands, and don't make eye contact. That's not a theory of autism. That's a description of certain autistic-like behaviors. And what we're doing with ADHD is describing certain ADHD-like behaviors. But can we formulate an underlying theory like we're trying to do with autism for ADHD? And I think the answer is yes, and I'll try to do that briefly this evening. And then I'm going to talk about some of the developments in treatment. To begin with, I would like you to sort of appreciate just the refinement that has gone on in the last decade of even the description of ADHD. Previously, we would just say that you're inattentive and you're hyperactive and impulsive. But now we can go much further and specify the kind of inattentiveness that you have. After all, there are 6 different kinds of inattention mediated by the human brain. Each has a different neural network. Each probably has different neurotransmitters that help to mediate this. And ADHD does not interfere with all 6 of those. So can we get more precise in defining what makes this an attention disorder as compared to the kind of inattentiveness we see in anxiety disorders, or in depression, or in the learning disabilities, or in schizophrenia? They also have attention problems. They're not all the same. So all inattention is not ADHD, nor is ADHD necessarily a disorder that influences all kinds of inattention. And we have gotten much more precise in showing that ADHD specifically is a problem with persistence toward the future, persistence toward a goal, the ability to sustain behavior over time toward a task, what lay people would call sustained attention, but what William James over 100 years ago referred to as persistence. This aspect of attention is quite unique because all other aspects of attention are on the information processing side of the human brain. And this is not. This is on the motor side of the human brain. This is how behavior is planned, organized, executed, and sustained toward a goal, all of which are largely output or motor functions of the brain, not perceptual functions. So it would be wrong to say that there is something perceptually wrong in ADHD. There's no mental filter out of whack. There's no altered perception of reality. The ADHD child sees the same reality as the child sitting next to them sees. Where they differ is that the ADHD individual reacts to that reality, responds to those events differently than other people. And one of those differences in responding is the inability to sustain that response until the task is accomplished, until the goal is achieved. So I think that's an important distinction because it will separate the kind of attention problem, because anxiety doesn't produce that. Depression doesn't produce that. Those aren't the kinds of things we see in the learning disabilities, which also have some attentional disturbances associated with them. The second problem with attention, which is of course very tightly linked to the first, is resistance to distraction. And that makes sense. You can see that they're opposite sides of a common coin. In other words, if you can persist, it's because you can resist interference. And if you're capable of resisting distraction, you can probably persist toward your goals. So they really are highly correlated with each other. The ability to resist interference is what assists us in our persistence toward the goals that we are holding in mind, the task we need to accomplish. So there is impaired distractibility. But unlike what lay people and teachers think, the distractibility isn't on the sensory side of our brain, as I've already said. The person with ADHD doesn't perceive a distracting event that you didn't hear or see. They hear and see the same thing you do and vice versa. The difference is they reacted to that distracting event. When the bird went by the window, when they heard the conversation in the hallway, when they heard the Harley Davidson go by the classroom, that provokes a response that other children suppress because it's irrelevant to the goal, to the task. The ability to suppress responding to irrelevant events is this distractibility. This is the child that gets up, goes to the window, looks out, starts talking about Harleys, says his dad has one, wants to know if you want one. By the way, did you go to the Myrtle Beach National Harley Convention? I went there last year. It's really kind of cool. Do you see what happens? They're off and running on this chain of tangential thinking and behaving. But that's a motor abnormality, not a sensory abnormality. So the idea that ADHD children are picking up on things that you and I don't perceive is ludicrous. Now, there is a third aspect to the attentional disturbance that fascinates Julie and myself and others who are here. Blythe, of course, you and I were talking about this as well. And that is ADHD individuals cannot hold in mind information that guides behavior toward a goal. And this shows up very clearly because when they're distracted, something they do that you and I don't do is they don't return to the task. You and I, when we're distracted, and you will be distracted because some events are too compelling to ignore, the phone call that comes in, for instance, that you have to take now, so you stop writing and you shift and talk. But what do? As soon as you hang up the phone, you go back to what you were doing. The ADHD person does not. That distracting event has now destroyed this capacity to keep the goal in mind. Now, holding information in mind that is guiding behavior toward a goal is working memory. That's the part of the brain that allows you to do that. So here we see that there's an aspect of ADHD that has nothing to do with attention. It has to do with the capacity to keep information in your head, actively in mind, while you are pursuing a goal. And in neuropsychology, we call that working memory, which lay people should simply refer to as this: remembering so as to do. It is a special kind of memory, which is why it's called working memory, which distinguishes it from the traditional memory system of the hippocampus and the storage and retrieval of information. This does not have to do with that system. This is a different system. Remembering to do. It's what you lose in your 50s when you're a guy, and it's what women lose in perimenopause, big time. What you are losing is the capacity to hold in mind what you were doing. And so you develop what my wife has affectionately called the but first syndrome. I went into my office because I needed to handle this. But I saw that bill needed to be paid, so I wrote out the check. And that led my attention over here to the Christmas plant that is now blooming, but I really ought to prune that. And you know, it looks a little dry. I better go get some water and take care of that. Oh, I'm wandering. I forgot I'm on camera here. My apologies. Illustrates the point. In other words, the now, the events around you, have become more compelling than what you were holding in mind. And so when people age or hit menopause, what you're experiencing is very similar to what people with ADHD have been experiencing since childhood. Simply magnify it by a factor of 10. But each of us has a little ADHD going on, particularly as working memory begins to decline. And in older life, you don't lose your memory, you lose your working memory. So that is a fascinating discovery because working memory is one of the 5 major executive functions. There may be more than 5, this is debatable, but most researchers acknowledge at least 5 distinct executive abilities. And if working memory is one of them, and that is deficient in ADHD, it does raise the question, are the others? Is this an executive disorder rather than an attention disorder? It certainly is more than an attention disorder. And it's findings like that and others that have led many of us in this field to begin exploring the other executive activities and whether ADHD individuals are deficient in those. And we'll talk about those shortly. But you can see then that certainly under inattention, we are coming to realize that it isn't inattention. It's more than inattention. And the DSM-5 is now going to reflect that. In the year 2011, it will relabel this list of symptoms as reflecting more than inattention, which it should do. Now, there's a second problem, which actually develops first, and it's an inhibition problem. And the hyperactivity comes from that. So that the excessive activity of the young ADHD child is not a distinct symptom from the others. It's part of the inhibitory problem. It's a preschooler's symptom of inhibition deficits. As the preschooler ages, the hyperactivity is going to decline quite markedly, such that by adolescence it is becoming more of a subjective, internal, feeling a need to be busy and to be engaging in multiple things that you never finish, but doing multiple things. And by adulthood, hyperactivity is of no value for diagnosis. It's one of the findings of my new book that I spoke about earlier today on adult ADHD, which is one of the first studies to show that in adults, restlessness is actually of no value for differential diagnosis. In fact, it tends to go with anxiety disorders by adulthood, not with adult ADHD. But the inhibition problem that gave rise to it, the impulsive thinking, the inability to control your motor reactions to things around you, persists much longer into adulthood and is one of the top 3 distinguishing features of the adult with ADHD. Makes impulsive decisions, fails to think before they act, and so on. So you need to understand that some of this sort of superficial hyperactivity may decline, but its underlying problem with inhibition is not declining quite so much. And you can see that here. So even though this is a description of people with ADHD, we've been able to refine that description further down to something more precise that allows us to say what ADHD is and what it isn't, and what an anxiety disorder is and what it isn't. There are no other disorders I'm aware of that produce these problems chronically, unremitting, dating from childhood. No other disorder does that. So if you'll focus on what is precise about ADHD, it really helps clinicians in their diagnosis of, is it this, is it that, is it bipolar, is it generalized anxiety? And now we can begin to do that because the other disorders don't do this in a chronic, unremitting course. Now, another advance has been in the typing of ADHD. Since 1994, we have been experimenting with a way of typing ADHD in our diagnostic manual. We've had 3 types. We've had people who only have the inattentive deficits and have less problems with hyperactive impulsive behavior. That's the inattentive group. We have the inverse group of people. And we have the majority who have both of these deficits, and we call them the combined type. And we've been studying this way of subtyping ADHD, and we can now ask the question, was this a useful scheme, a useful strategy? Or did this turn out to be simply the result of the fact that we had 2 lists? And as with a Chinese restaurant menu, if you have column A and column B, you can make 3 things out of 2 columns. In other words, it's not very useful. And the answer turns out to be the second one. And so in 2011, we will abandon this approach because it has no clinical or research value. It turns out that ADHD isn't 3 things. It's 1 thing. And these are simply variations in severity. Because people move from these into these and from here over to here because their hyperactivity is declining. But the DSM presents this as 3 types of something, when in fact it's a dimension that varies in severity. And it's a single disorder in the population. So this will be gotten rid of. Now, what's to replace it? Well, the Europeans have been doing something that we have avoided doing, but it turns out they were probably right. For at least 20 years, they have subtyped hyperkinetic disorder, which is what they called this for many years, into those who were hyperactive with conduct disorder and without conduct disorder. We in the US and North America more generally viewed this as simply comorbidity. One disorder just happened to occur with another. And therefore, if we were correct, what you should see in the combined group is what you would expect if you added one disorder to the second disorder. An additive finding. But in fact, when you study the combined group, what you find is it's not additive. It's quantumly worse. Both disorders start much earlier in the combined group. Both disorders are highly persistent, much more so over development than when each disorder occurs alone. The families that give rise to these combined children are markedly more impaired, with much higher rates of psychiatric disorders, particularly antisocial personality disorder, alcoholism, drug use, and major depression. We know that 1 in 5 of these children will have the traits we associate with adult psychopathy, the psychopath. These are what we call the callous, unemotional traits of lack of empathy, lack of conscience, lack of guilt and remorse. And combined with that is an instrumental, predatory form of intentional aggression. They prey on other people. And this starts very early in the lives of these children. Paul Frick has shown that we can identify psychopathic children, not just adults, and that they're likely to be found within this group. ADHD alone does not give rise to the psychopath. Neither does conduct disorder alone. So there is something about this combination that does so, which is just one more example of why, when they occur together, it isn't just overlap. It's a distinct form of ADHD. So those of us who do behavioral genetic studies are now studying them as a separate group. I think that neuroimaging people might want to take a second look at that as well, because if you combine them in with your purely ADHD group, you're adding in noise when you could have had more homogeneous groups of people. Because we now believe that there are physiological differences between these groups. For instance, this group shows a much more reduced response to stress, whether measured through the hypopituitary axis and cortisol secretion in saliva, whether measured through the parasympathetic nervous system and one's galvanic skin response and heart rate deceleration and respiratory changes. These individuals have a marked altered response, a lower response to stress than do ordinary children or ADHD children. So there is something about these individuals, both biologically, psychiatrically, developmentally, and familially, that points to this being a distinct group of people. And I think you'll see in DSM-5 we're likely to use that as a more useful approach for clinicians to subtype their patients than this far less useful view of ADHD. Now, we can dispense with the hyperactive type because it turns out to simply be the preschool stage of the combined type, in which longitudinal studies have shown that over 90% of people called this type eventually get the combined type. You just caught them young, and that's because the hyperactive and impulsive symptoms start earlier than the inattention and executive deficits do, but within 3 to 4 years they will be combined type. And even if they aren't, they miss it by just a single symptom, which means they're just a milder variant of the combined type. Now, there are a few children in here who are ODD only, oppositional only. I won't say much about them, but it's simply a group of children where parents confuse oppositional behavior with ADHD, and as the oppositional disorder is outgrown, the ADHD disappears. And that's because oppositional disorder, when it occurs alone, is benign, and 50% of all cases disappear every 2 years of follow-up. Now, when oppositional disorder occurs with another disorder, like bipolar disorder or ADHD or conduct disorder, it is a highly persistent disorder. But occurring alone, it is not a disorder to get very excited about. And that's usually what we're seeing here. I'm not going to spend any more time on those kids. But the lesson there is that there is no hyperactive type. It never was. Now, this is a group of children worthy of more comment, because while some of these children are clearly variations of our combined type children, and need to be reclassified as such. There is a group left over who are quite different. And it's anywhere from 30 to 50% of all children called inattentive only ADHD children. Researchers have invented a term for these. It's not a diagnosis. If you use it outside this room, most clinicians have never heard of it. But in the research literature, this is the term that is being used to describe this unique group of individuals. I believe this is a separate disorder from ADHD, that lurking within the larger sample of ADHD has been another attention disorder. But even my conservative colleagues, like Steve Hinshaw, just down the road at UC Berkeley, even though he would say that maybe it isn't a separate disorder, would agree that it's qualitatively different from the combined type of ADHD. Whether you're in the disorder camp or the subtype camp, I don't care. The finding that is important tonight is that there are many qualitative differences that are worthy of appreciation. First of all, the symptoms shown in the SCT child are the opposite of ADHD symptoms. This is a staring child, a daydreamy child, a passive child who is lethargic, slow-moving, sluggish, stares. This is the child that is often viewed as mentally spacey, foggy, and appears to not be attending well to reality around them. Those, in many cases, are the antithesis of the ADHD child, who is distractible, impulsive, active, engaging, in your face. If an ADHD child were to come into this room, you would know it in minutes. If an SCT child were to come into this room, you would never know it. So the difference in their disruptive value to the environment is quite striking. This is not a disruptive group of children. The ADHD child is clearly a disruptive child. Now, there are other differences. ADHD is not an information processing disorder. This is, suggesting there's something in the peripheral or in the sensory analyzers of the brain, the posterior aspects of the brain, where this disorder lies. Those of us in neuropsychology are tantalized by the finding that the symptoms and the processing problems remind us of children who have white matter disease of the brain, where there's been a disruption in the cortical, subcortical loops of processing information, which ADHD children do not show. Now, I don't know that that's the source of their problem. I'm just drawing an analogy here. The pattern of cognitive impairment resembles that of other posterior disorders and not of the ADHD child. When we look at the kind of attention impaired, out of the 6 dimensions of attention, these children are impaired in selective attention, to the ability to identify rapidly what is important in front of you from what is not. Some people call that focused attention, but it's really a selective aspect of attention. When we look at their memory systems, the ADHD child has a working memory problem. They forget to do. These children seem to have a retrieval problem out of storage of memory. But I add a question mark because it's very understudied, so I don't want to pass it off as something definitive, certainly worth further examination. What is much more definitive is that the social impairments of these children are the opposite of ADHD children. These are shy children, reticent, apprehensive, less involved. Now, unlike the Asperger's and autistic spectrum disorders, or the schizotypal or schizophrenic disorders, they're not aloof and disinterested in other people. It's not that they have a disregard for socializing with others that is so much more typical of the autistic spectrum children. They do want friends, they are interested, and they have appropriate social skills. They're just a little more anxious, a little shy, a little hesitant. But you don't see the awkwardness that you see in the ASP and in the schizotypal children. You don't see the bizarre aspects of interaction that typify those other children. So what you're really seeing here is a wallflower. These children have friends, not as many as normal children, but far more than ADHD children do. The ADHD child is likely to be friendless by 2nd or 3rd grade. That is not true of these children. These children, by definition, have no inhibitory deficit. ADHD at its core is an inhibition disorder. If we were to place in primacy one of the 3 symptoms of ADHD, it would be the inhibition problem. that is one of the central features that theorists have repeatedly gone back to as part of ADHD. That is not the case with this disorder. This alone supports my argument that this is a separate disorder, because these children lack the very core feature that defines the ADHD child, which is the inhibition problem. There are differences in comorbidity. The disorders that go with ADHD are quite different. ADHD children have markedly high risk for oppositional disorder, as I mentioned in my previous talk this afternoon. And a substantial minority go on to develop conduct disorder. These children carry very low rates for those disorders, probably no higher than the population rate, or if they are, they're insignificantly higher. Whereas the ADHD child, markedly higher. In contrast, research is quite convincing that anxiety is much more a feature of this group of children than even of ADHD children. Now, about 25% of ADHD children have an anxiety disorder, but the rates are higher among these children. It's less clear that depression is elevated. We used to think that it was, but ADHD children carry a risk of depression too, and the differences are not impressive, at least not at this point. They're more impressive for anxiety. Both children suffer in school, equally in fact, but if one studies the kind of mistakes, the reason behind the school failure, they too seem to be qualitatively different. These children have more problems with errors in schoolwork. The ADHD child has problems with production of work, number of problems done. And although I've oversimplified, since both groups of children probably have both kinds of problems, the relative proportion of errors, I think, is worth emphasizing. The ADHD child has a production disorder primarily. This child has an accuracy disorder. Now, these children have been found to be more likely to have math disorders, but I don't want to overplay the point because only a few studies have looked at this. But we know that children with math disorders have a pattern of inattentiveness very similar to what we see here, and markedly different from what is seen in ADHD. A comprehensive review of all research on math disorders, published just a few months ago, made this point very clearly, that there are different attention problems associated with math problems, suggesting, again, that these children might be more prone to those problems. The families are different. ADHD families have more ADHD, more school failure, more conduct problems, and more drug use problems. These children come from families with more learning disabilities and more anxiety disorders. But we only have a couple of studies, and again, emphasizing it's not a definitive finding on family history. What is beginning to become clear in the last 5 years is that there are differences in treatment response. The most compelling evidence was the stimulant studies, mainly done with methylphenidate, none with Adderall or the amphetamines, and certainly none with atomoxetine, which is Strattera. But certainly the methylphenidate studies show that the response of these children to stimulants is unimpressive. My own study at UMass, done when Julie was back there, she probably has forgotten this, shows about a 20% rate of response among these children versus over 92% of combined type children in that study responded to one or more of the doses of stimulants. Now, ours was one of the few dose response studies. Others have simply found a rather lackluster or mediocre response. I want to make the point clear here. We're not saying that stimulants make these children worse. What we're saying is that they don't help them. The response is not dramatic. It's not clinically impressive. You wouldn't argue for keeping this child on medication after the trial. So even though there's a slight improvement, it's not worth the money, the side effects, the effort to retain them on the trial. So we're beginning to see the potential evidence that stimulants are not really the drugs for these children like they are for combined type ADHD. There is a growing body of evidence that these children are among the best responders to social skills training. ADHD children either don't respond to social skills training or the skill training response is very unimpressive and does not generalize outside the training environment. And in 1 in 4 ADHD children, they actually get worse. People need to understand that social skills training produces side effects, that some children engage in what we call deviancy training, where aggressive children in the group train up the non-aggressive children to become more aggressive children in defense. By the way, this is seen every year in kindergarten, so it's not a new finding. young children who first start school in kindergarten become much more aggressive during the first 3 to 6 months of kindergarten. So there is a downside to social skills training that clinicians should not ignore. We need to remember that social skills training was originally invented in the 1960s for the treatment of shyness, and it continues to show its most robust effects with anxious, internalizing, and reticent people. The data on people with disruptive acting out disorders is much less impressive than it is on internalizing disorders. And that begins to explain why it's the shy ADHD child who seems to respond so well here, as opposed to the disruptive ADHD child. Now, I will argue that these children might do better in behavioral interventions. There's no study of that, however. But we can logically draw this inference, at least as a potential reason to further research it, because the large study known as the MTA study, largest study ever done of ADHD treatment, found that the single best predictor of who did well in treatment was anxiety. The more anxious you were, the better you responded to the psychological and behavioral and school interventions. And since these are the most anxious of the ADHD group, it would lead one to argue that they may well be our best responders to psychosocial treatment. We might find here what we're already seeing for social skills training. Now, cognitive training, which is teaching children to talk to themselves, has been tested extensively for ADHD, and it fails. We do not recommend it as an intervention. It works better for anxiety, for depression, for internalizing symptoms. But hold on, this isn't ADHD. So don't throw the baby out with the bath here and assume that because a treatment failed for ADHD, it shouldn't be used for SCT. I actually believe there is good reason to think that a cognitive training program would assist these children. First of all, cognitive therapy helps anxious people, so it might well help them, if only with their anxiety. But because these children appear to have normal internal language, whereas ADHD children are delayed in internal language, cognitive therapy might work for these children, whereas it doesn't work for ADHD because of this failure to develop appropriate internal speech. And then finally, I have pressured the Lilly company to test Strattera with these children. And the reason I've asked them to do so, and they are now doing so, is because of a study published a few months ago showing that Strattera treats anxiety when it co-occurs with ADHD. Stimulants do not treat anxiety, and there is a robust literature suggesting it probably worsens it in some children, though not in all. But here is an instance where we have a drug that treats both disorders. Maybe it would help these children. Neuropsychologists and neuroscientists in the room also would recognize that the kind of attention problem seen here certainly mimics those that are associated with norepinephrine disorders and might well be more responsive to a norepinephrine agent, which is what Strattera is. And so just another hypothesis, not proof. Don't leave here saying, Barkley says Strattera treats SCT. I have not said that. I can say it right into the camera. Don't you dare say that I said that. But it's a reason why science would want to look more closely at that. Enough said. What we can say then in the last decade, we found another disorder. It seems to be within the ADHD population, but probably isn't ADHD. I'm not sure yet whether it's a distinct kind of ADHD, as others argue, or whether my earlier suspicions are true that it's actually a separate disorder and needs to be treated as such in DSM-5. The DSM-5 committee will study the matter further. Now, if any area has seen advances in the last decade, it has been in etiology, the causes of ADHD. We can now say, without a doubt, that ADHD is multi-causal. There are many roads to Rome, ways to get ADHD. We can just as safely say that none of them fall within the domain of social factors. It is impossible to take a normal child and expose them to anything societal and produce this disorder. And I believe that can be made now unequivocally. All of the known causes of ADHD are in the biological factors, particularly the realm of neurology and genetics, which are not dissociated from each other, but are in fact related fields of etiology. And we now know that there can be multiple causes within these domains that compound each other and interact with each other to produce ADHD. We are beginning to find through work such as Julie's work here on neuroimaging, many other studies such as the initial Zametkin studies in the 1990s, and the MRI and fMRI and PET and SPECT and other neuroimaging devices, that ADHD is associated with at least 4 brain regions that have been referred to by these 3 as the frontostriatal cerebellar circuitry, now known to be the inhibition circuit of the brain. The size of this circuit, the amount of activity within the circuitry is directly related to impulse control. So we're beginning to make some very broad conclusions about causation, but we can now dismiss the absolutely ridiculous claims, such as the syndicated columnist John Roseman, that ADHD is the result of television, of poor disciplining, of lack of love, or the notion of Peter Bregan and the Scientologists that ADHD is the result of family factors and not the result of biological factors. We now have many studies that can disprove these ideas. We have learned from many studies, especially summarized in the brilliant textbook by Joel Nigg published last summer on what causes ADHD, that about 1/3 of ADHD is acquired due to central nervous system injuries, most of which occur prenatally. And you can see here a list of the factors that have been identified reliably, some that we have strong suspicions about, but still need further research associated with them, some that we can rule out. And while cocaine-exposed babies have high rates of ADHD, research now shows it isn't the cocaine. It's what these women do to themselves. Women who are crack abusers are polydrug abusers. They smoke, they drink, they have high rates of adult ADHD, they're malnourished, and they have premature babies. Those are the things that are causing their babies ADHD, not actually the use of the cocaine itself. So we're learning then about prenatal factors that contribute. A small percentage of ADHD is clearly caused by postnatal injuries after birth, such things as you might expect: head trauma, blunt trauma, for instance, or even penetrating head wounds. Lead poisoning has a long and rich history of association with ADHD. We know that lead is a toxin to the human brain, that it has a particular affinity for the frontal lobes, and especially for the dopamine pathways. So it's understood why that might be the case. We've known that children with leukemia can develop a post-leukemia ADHD, but it now resembles more the SCT pattern of symptoms I've mentioned, which explains why the stimulants are not showing a very impressive response in treating children who survive leukemia for their post-treatment ADHD. There's some fascinating work on the role of the immune system and ADHD. Brad Peterson's is the one I'm more familiar, but I learned this morning in meeting with a number of scientists here of some absolutely fascinating cutting-edge research going on here at the Mind Institute on the role of immune factors in the immune system, not only in autism, but probably in ADHD as well. And of course, we've known that children with PKU have high rates of ADHD and of the executive deficits that go with them. But we're now finding that one doesn't have to have the severe condition of phenylketonuria, that just higher than normal levels of the chemical involved in PKU, which is phenylalanine in both the mother's and the baby's bloodstream, is associated with higher rates of executive deficits in ADHD, suggesting that one doesn't have to be so toxic with phenylalanine as to be PKU, but just higher than normal levels may be poisoning the frontal system and the executive activities that take place there. We know from Julie's research, from Castellanos and many others, that the brains of ADHD children are smaller and less mature. Not enough that neuroimaging can be used for a diagnosis, but enough that when we average groups of ADHD scans together, we can begin to see about a 3 to 10% smaller area of brain development in the orbital frontal cortex, particularly the right side, in the basal ganglia deep inside the brain, particularly the striatum, in the cerebellum, and again, more on the right than the left, and also within the anterior cingulate, although the anterior cingulate doesn't necessarily seem to be smaller, as Julie's research has shown, and others, by George Bush, for instance, at Harvard, not the George Bush, another George Bush, not W, but Bush's research, like Julie's, finds that the anterior cingulate is massively underactive. in various tasks that ADHD people have trouble with. And we know from Shaw's research that these are persistent findings over time from childhood to adolescence. And contrary to the claims of Scientologists, these are not the result of giving stimulants to children, but are found in stimulant-naive children, never treated previously. The regions we're talking about are the right orbital frontal area here. This is the basal ganglia deep inside the brain, particularly the striatum, which is this C-like structure here, and then the cerebellum, which is a very primitive structure at the back of the brain. And it's mainly the central area here as well. You can see it here as well in the functional deficits. This is some of the research by Beth Casey showing that there are both, here is the anterior cingulate, the medial aspect of the frontal lobe, as well as the right frontal lobe, showing that it is associated with patterns of underactivity in people with ADHD, and you can see a separation in function between normal and ADHD individuals in this relatively recent study. This is a study published just a month ago, absolutely fascinating serial neuroimaging study. And this study was by Phil Shaw and his colleagues at the NIH. And you can see here they scanned children every few years 4 different times across development, and then computed which areas of the brain were behind at least 2 years or more in their maturation to normal brain size. Now, it's important to understand this is a study of structure, brain size, not a study of function. But what you are seeing here, in the darker the blue, the greater the delay, are the areas of the brain that are at least 2 years behind in their maturation. One can see it here graphically if one plots the maturational curves for normal children and for ADHD children. The difference, of course, showing the delay to reaching full structural brain size in ADHD. It's just one of many studies showing that there is a neurobiological basis to this disorder, and quite consistent with our view that this is a developmental disorder, not an aberration or a psychopathology, that it represents a delay in maturation. A fascinating finding in the study is that there is a small region in the brain that is overdeveloped too early in ADHD children. It matures too quickly. And many of you, if you know neuroscience, know this is the brain's primary motor strip. And basically what you can conclude from this study is that this is probably the source of the hyperactivity. You've got an over-mature motor system and an under-mature executive system that ordinarily would be regulating it. And hence you have a hyperactive, dysregulated individual. Now, important to emphasize is that Bush's study took no measures of symptoms. It can say nothing about whether or not these individuals are normal by adolescence. As I showed you in my earlier talk today, they're not. And certainly this is not a study of brain function. Functional neuroimaging studies like Julie's and others done here and elsewhere clearly show that there are functional differences in children and adults with ADHD. But the Shaw study is remarkable in, once again, documenting the developmental delay that ADHD produces. Now, I won't spend time on here. I show this slide only to illustrate the complexity of the neuroscience research going on. We know there are at least 3 different circuits within these brain structures, not one, and that each of these, while regulated to a large extent by dopamine, may produce different symptoms and different behavioral expressions, so that some children might be disturbed in one aspect of the pathway, others in 2 or 3, helping to explain some of the heterogeneity that we see in ADHD. Some very fascinating research by Terry Sagvolden, more recently by Joel Nigg and Javier Castellanos on brain circuitry. That's just to show you, like a TV schematic, that there are these 3 brain circuits, each of which involves dopamine, but each of which would produce a different set of deficits in ADHD individuals. Why is the brain smaller? Well, I think genetics holds the answer. We've known for decades, since the early studies by Morrison at Iowa and Dennis Cantwell at UCLA. I have the honor of being this year's Cantwell lecturer next Tuesday at the Neuropsychiatric Institute at UCLA, in honor of Dennis's work. But going all the way back to even when I was an undergraduate, we've known that ADHD is a strongly inherited disorder. You can see the risk to relatives if a child has ADHD, the higher risk to siblings and twins, and the fact that their parents are likely to have the same disorder. And look at the marked elevation if the parent has ADHD in the risk to children. It averages 40 to 50%, meaning if you're an adult with ADHD, half of your children are going to express this disorder. A markedly higher elevation. A fascinating finding for researchers, but I don't want to dwell on it too much, is the first paper demonstrating the possibility of imprinting in the genes for ADHD. We know that mammals, when they give their genes to their offspring, are likely to tag the gene with a little flag called a methyl group that tells whether the gene came from the mother or the father. And the gene seems to express differently depending upon its origin. And although the gene itself is identical when you look at its sequence, the way it activates is different depending upon which sex it came from. So that the parent seems to imprint their genes with the gender of origin. And Guz and Shaker at the Hospital for Sick Children have published the first study suggesting that there may be genetic imprinting in ADHD, depending upon whether the genes come down from the father's or the mother's side of the family, may alter the expression and severity of the ADHD, and to some extent determine risk for other comorbid disorders. Now, this needs to be replicated, but I'm just trying to show you the excitement in this area of research and the fact that we're beginning to see a novel area of research never before studied in psychiatric disorders in children. And that is the notion that although genes may be identical, the gender of origin of the gene, the parent contributing the gene, may well alter the expression of that gene to some extent. Now, we know from many twin studies, now numbering more than 40, one of the most reliable findings in research on ADHD is the striking heritability. Heritability is a number we calculate in twin studies that tells us how much of the variation in the human population in that trait is the result of differences in our genes. Take human height, for instance. If I were to measure all of you and plot your height on a distribution, I could show that 91% of the variation in height among people in this room is entirely due to differences in your genes. And you would understand that. Tall families give rise to tall children, short families to short children. Obviously, this being a physical trait, genes are playing a very instrumental role in human variation in height. But what we're finding here is that the variation in ADHD symptoms in the human population is just as genetically influenced as human height. Indeed, ADHD is among the top 3 genetically influenced psychiatric disorders ever discovered, rivaled only by autism and bipolar disorder. And we are seeing that the traits that make up ADHD, these executive, inattentive, and impulsive traits, are among the most strongly genetically influenced psychological traits ever discovered by science. Intelligence is not this strongly genetically influenced. Anxiety carries only a 30 to 40% genetic influence, less than half of what we see in ADHD, suggesting that we are seeing a marked contribution to genetics in its contribution to the frontal cortex and specifically to the symptoms that underlie ADHD as well. Now, twin studies are uniform across all studies in showing no role of the rearing environment in this disorder, which is why John Roseman is absolutely, utterly wrong. He's not only wrong, he's worse than wrong. To be worse than wrong is to make a declarative statement about what we know in the face of all research pointing to the contrary. It would be like denying gravitational effects on the Earth's surface. And yet we see many people who still believe in the role of parenting as a contributor to ADHD. And the twin studies say this simply is not true. If you're looking for an environmental effect, look at something unique that happened only to this child, not to other family members. And here is where we would see the biological hazards we've already discussed. The smoking, the drinking, the prematurity, and the biohazards. The high heritability has led researchers to begin searching for genes for ADHD. And ADHD has been one of the most successful psychiatric disorders in terms of identifying reliable candidate genes. Better than bipolar disorder, better than autism, we have been able to identify a set of very reliable genes. Not necessarily found in all studies because ADHD is genetically heterogeneous, but in enough studies to show, when we do what's called a meta-analysis, that these genes seem to be holding up. And the most reliable ones are at the top and then further down the page. Even just a month ago, The Finnish studies of ADHD again show these genes, particularly DBH, as a candidate gene for ADHD. Now, I can't go into what these genes do. You can read about them here quickly. But the point is that most of these have a D in front of them, which means they regulate dopamine in the human brain. So we're beginning to define that dopamine genes are quite likely to be involved in ADHD. Also probably are norepinephrine genes, because some of these genes, such as DAT1, don't just influence dopamine genes, but also norepinephrine reuptake and the norepinephrine transporter as well. Now, what you may not know is that within the last year, research has found that this gene predicts who will respond to methylphenidate and strattera, opening the door to the possibility that in very near future, we will be able to do genetic typing of children and choose the most appropriate drug without what we do now, which is purely flying blind and putting children on medicines and waiting to see what happens. It's going to be a fascinating area of research. Now, I don't want to overplay that. There was a failure to replicate that finding, but there are 2 studies to show that it does. So it leaves open the possibility that genes determine the best drugs that you respond to. Now, lastly, I want to emphasize an advance here by Richard Todd's group in St. Louis that shows that there's probably an interaction between environmental biohazards and genetic risk. And we can see that here quite clearly. This is whether your mother smoked during pregnancy or not, no or yes. This is whether you have the DAT gene I've already mentioned, plus meaning you do, minus means you don't have that risk gene. And then here's the DRD4 gene. Look at what happens as we begin combining risk genes with an environmental toxin. The most important finding is here. If you are a fetus that carries both risk genes and your mother smokes during pregnancy, you are 8 times more likely to get this disorder than anybody with any of those single causes. That is a clear gene by environment interaction. It's also now been found for alcohol, and it's beginning to be found in other disorders as well, suggesting that things are more complicated than we thought. It isn't just one or the other. There probably is some interactive effect, and I think, as I learned this morning, the same thing is probably going to be found for autism as well. So what can we expect in the future? You and I can expect that probably in the next 5 to 10 years, all of the risk genes for ADHD will be known. It looks like there's probably going to be at least 20 of them because we've now scanned the entire human genome, and that's the number that seems to be coming up as far as locations on chromosomes. So it's a polygenetic disorder. But that's going to let us subtype people based on their genetics, and we're probably going to find that there are different kinds of ADHD and different life course risks. My own Milwaukee study has genotyped all of the children and found that DAT1 is a predictor of severity of ADHD, of risk for cigarette addiction, of your workplace evaluations in your work performance, and of your grade point average in high school. All of which just sort of titillates us a little bit to suggest that some genes have life course expression and carry risks for certain kinds of impairment. And while my study needs to be replicated, I understand Jim Swanson is finding very similar effects for the DRD4 gene and others, so that we may see that depending upon which of these genes you get and in what combination, there are different risks associated with your kind of ADHD and not others. And as I've already mentioned, we're beginning to see that genes may predict drug response. We may see drug companies developing utterly new chemicals for your genotype, which of course is something that is not space-age technology here, but is well within our grasp once we know what these genes are and how they express in the human brain. And there may well be the, I think, fascinating possibility that genes don't just predict response to drugs, they probably predict response to psychosocial treatments as well. To summarize, advances in research show that ADHD is a neurogenetic disorder, that about 2/3 of all cases are of the familial genetic type, that the remainder are due to various injurious events that take place most often prenatally, but some postnatally, and that no one sees up here parenting, TV, video games, sugar, and the more popular notions that lay people have about ADHD, but have turned out to be false. Now, my time is running out, and I could spend an entire hour on this, but I simply want to point out that we're building models of ADHD as a disorder of the executive system, that we can break the executive system not only into inhibition, which is the principal executive deficit, but into 4 others. There's the nonverbal working memory system, which I have reinterpreted in my writings as the visual imagery system. There's the verbal working memory system, which according to Vygotsky is really just self-speech, the voice in the mind. There's the emotion regulation system, which I believe is the same one that gives us self-motivation. And there is the planning mechanism, which generates potential responses. It's sort of the innovative problem solving, almost like a simulator would be, allowing you to simulate mentally multiple possible ways of getting to your goals and choosing the most effective among them to, in fact, put into play. Research is beginning to show that ADHD interferes with all 5 of these executive systems, which means that ADHD children aren't just uninhibited. They also have problems with visual imagery and nonverbal working memory, which, by the way, if you're not familiar with it, is the origin of the sense of time, the subjective awareness of time, which explains why ADHD so disrupts the individual's ability to deal with time, why they're always late, never prepared, never organized. Begins to explain why ADHD children can't follow rules and instructions, because their internal language is 30 to 40% behind normal children. And it's internal language that allows us to do what we're told and to govern our own behavior by what we tell ourselves to do. It explains very clearly why ADHD children have a motivation deficit, why they can play video games for hours because the motivation is external and provided as a continuous reinforcement schedule, but why they can't do homework for minutes because homework provides no consequences and demands internal motivation, self-created motivation. ADHD is a self-motivation deficit disorder, which is why they can't function well in environments where there are no consequences for immediate gratification. It also explains why they are so poor at problem solving, at generating potential possible ways of solving their problems, and why we see this in fluency, both verbal, spatial, and motor fluency tasks, suggesting that there is a problem with the planning mechanism as well. I wish I could go over this in more detail, but I'll just leave you with the implications of an executive view of ADHD. Viewing ADHD as an executive disorder tells us that ADHD is a form of time blindness, that ADHD children have a nearsightedness to the future, that future events have to be immediate and compelling before the individual is capable of dealing with them, that events that lie at a distance across time are of no value to these children. They can't muster anticipatory responses and prepare for future events. To put it in another way, the ADHD individual lives in the now, and past and future are of little consequence in the regulation of their behavior. It tells us that ADHD is not a disorder of knowing what to do, but a disorder of doing what you know, that it's a performance problem, that the ADHD child will not benefit from skill training because they know what other children know. What they can't do is do what other children do with that knowledge. Think of your brain as a 2-part system. The posterior part of the brain is the information acquisition system. It is where knowledge is acquired and stored. The frontal part of the brain is the system that puts what you know into everyday adaptive functioning. It's where the rubber meets the road. It's where you use what you know to be as socially effective as you are able to be. ADHD, like a meat cleaver, has separated these 2 mechanisms so that what is known does not carry forward to influence what is done. And even the most brilliant ADHD people does stupid things in life. And we begin to understand this distinction between performance aspects of functioning and knowledge aspects. And it begins to tell us therapeutically what not to do. Don't emphasize skill training. People with ADHD are not stupid. They're not ignorant. They know what other people their age usually know. The problem is in implementing what they know. They can't do what they know at critical points in the environment that we call the point of performance. And what a theory like this tells us is something no other view of ADHD would say. The only treatment to treat a performance disorder must be at that point of performance. Treatments done away from that point of performance will be of absolutely no value to dealing with performance disorders. You must rearrange these critical natural environments where the problems occur to help them show what they know, to use what they have, and not put them in long-term psychotherapy or play groups or other things that have no bearing on the point of performance. The implications for treatment, I've already mentioned, they are numerous. Skill training is not enough. We need to work at the point of performance. We need to look at medication from a very different perspective. Medication for ADHD is not psychopharmacology. It is neurogenetic therapy. We can demonstrate that right down to the influence of single genes and the way they regulate transport mechanisms and postsynaptic sensitivities in single nerve cells in the human brain. We are no longer at an age where we don't know where ADHD comes from. We are actually working at the level of molecular mechanisms on brain cells and proteins that operate in those brain cells. And we can see exactly what these medications do. We know that methylphenidate blocks the transporter, and that ADHD individuals have more transporters on their nerve cells because ADHD children have longer transporter genes, and longer genes build greater transport mechanisms. So we can link genes to a brain mechanism, to a drug response, in a very interesting closed loop now that we've never been able to close before in our explanations of ADHD. And I believe that we need to represent this appropriately to the public. Using medication for ADHD is tantamount to insulin to a diabetic. It is literally a form of genetic treatment at the level of nerve cells within the brain. You're not papering over everything. You're not masking the problem. You're not failing to do with some hidden psychodynamic or intrafamilial conflict. None of those are pertinent. You literally are treating the disorder at its source. And that is an important take-home message for many families. And I am out of time. I could go through many, many developments. Let me leave you with some of the developments in treatment. We now have an array of medications for ADHD, the stimulants of which there are two types, but of which there are many different delivery systems, and more recently, the non-stimulants such as Strattera, the only non-stimulant approved for ADHD, but of course other drugs like antihypertensives, tricyclic antidepressants that also have a track record of helping to treat ADHD, though clearly not as dramatically as the stimulants do. What is new in ADHD research is that we have 5 delivery systems now, the 5 Ps, which people need, I think, to appreciate because some of this is new as of the last 6 months. We have the pills, which are the immediate release methylphenidate and amphetamine compounds that we've had going back to the 1950s and the 1930s. But we now have the methylphenidate pump, which is Concerta, which is a miniature, almost like a tube of toothpaste, that when swallowed excretes liquid methylphenidate for a period of 8 to 12 hours, providing much more continuous coverage in the ADHD individual. This is what medication 3 times a day would do with immediate Ritalin, and this is what happens when you squirt out liquid methylphenidate using this pumping system. You get a nice, even, continuous blood flow or blood level that eliminates the valleys and the lack of control from the immediate release. Absolutely ingenious system invented by Alza Pharmaceuticals and bought up by Johnson & Johnson. We have the pellet technology system, which is like the old contact cold medicines. Different pellets of methylphenidate or Adderall coated with different time release that dissolve at different hours of the day, some dissolving immediately upon ingestion, others an hour, 2, 3, 4, 5, all the way up to 8 to 10 hours of coverage. Again, this is what you would get with the immediate release amphetamine, and this is what you would get from a pellet system. It takes away the valley, provides a smoother gradation of coverage across the day. Absolute godsend for ADHD children because these extended release systems have now eliminated the need to administer medicines at noontime in the schools and the associated stigma and humiliation that many children were exposed to for many years. We also have the patch system, the 4th P, which is Daytrana, methylphenidate in a skin patch, which can be absorbed continuously through the skin, eliminating the need to swallow medicines. The upside, of course, is you get continuous coverage across the day. The downside is you got to take this patch off a couple hours before bedtime or you're not going to sleep. And the other downside is 1 in 4 people get a skin rash that is quite annoying and is the methylphenidate irritation of the skin. But again, another delivery system helping us to reach out to some cases of ADHD where a non-oral delivery system would be better. And finally, last August, comes the most recent invention that the FDA had to create a new name for, and that is the prodrug system. This is Adderall, but reformulated into a drug called Vyvanse. Vyvanse is an absolutely fascinating mechanism because what Vyvanse is amphetamine bound up with a lysine compound that prevents the amphetamine from being activated anywhere except in the stomach and upper intestine. Only in that area will this drug activate, because in the stomach and upper intestine there is a protein that splits the lysine compound off from the amphetamine, allowing the amphetamine to go to work. This is the first non-abusable amphetamine ever invented. Now, as a byproduct, not a downside, but an upside, totally accidental, it turns out that this binding mechanism gives you 2 to 3 more hours of coverage. This drug will last 12 to 14 hours. It's one of the longer acting stimulants currently available, which for adults in particular is extraordinarily beneficial because of the longer hours of responsibility that adults have. Now, we have seen developments in psychosocial treatments. Time doesn't permit me to go through all of them. And we've seen a number of new treatments being proposed and tested that continue to remain experimental, not yet proven, shouldn't be offered to the public, although they have been. But biofeedback, for instance, where we've got lots of promising uncontrolled studies, 2 randomized trials, actually now 3 that didn't find anything, so that needs to get sorted out. We've got cognitive training of working memory, 1 positive study, but we're waiting to see if it replicates. We've got Howard Abakoff's work on training children in time management and organization. Howard is using my theory of ADHD, in that ADHD creates a massive problem with the human sense of time, and Howard's trying to show that can we get in and train that up if we catch children young enough. So he's got a manual for schools and for families on time management training. Brad Smith and others are working on after-school programs for teenagers. They're the most recalcitrant, non-compliant group of ADHD people. And what Brad and others have done is to create after-school programs where teens don't have to go anywhere. They simply stay at school, go to a particular room. In comes a paraprofessional trained by an ADHD expert to offer after-school services, whether that's tutoring, whether that's social skills, whether that's assistance with their sports, or other areas of ADHD such as time management. The teenager doesn't have to go anywhere. There's no stigma associated with going to a psychiatry clinic. It really eliminates some of the hurdles to compliance among ADHD teens. Very fascinating experimental program going on both in Virginia and in Carolina. And then, of course, Steve Safran's work, and independently that of Russ Ramsey and Rothstein at University of Pennsylvania, showing that cognitive behavioral training, although it fails for ADHD children, appears to be effective as a supplement for medications for ADHD adults. So I hope I've left you with the idea that this is a rapidly advancing area of research in ADHD. We're learning lots of new stuff. Continues to be a very exciting area. Not once in my 34 years of work in this area have I been bored. There's always something new coming at us. And one of the things we can now say is that ADHD, although it's certainly not a benign disorder, as I said earlier, is among the most treatable psychiatric disorders. We have more treatments that are more effective for more people, believe it or not, than in any area of psychiatry. So there's a great deal of hope that we can provide a better future for these children and adults than we've previously been able to do. Thank you all so much.
Excuse me, I just want to announce for people, several people have asked about getting copies of this wonderful presentation. And we'd like people to know in about 2 weeks or so on the Mind UC Davis website on the internet, copies of this talk and the 4 o'clock talk will be available. I think, do we have time for a few questions?
It's up to you.
Okay, we have time for about 5 minutes worth of questions.
Would you? Julie's going to serve as a moderator.
Over here.
Is it possible to start using like sheltered workshop for programs for people at work with ADHD and have them come in and have behavior modification at work?
Well, certainly a variation of that. I hate to refer to it as sheltered workshops because that's a particular intervention that's been used for more profoundly developmentally disabled individuals. But one could certainly liken the Bill Pelham Summer Treatment Program and the other intensive intervention programs as being akin to that sort of a controlled environment where people come for 6 or 7 hours a day and are exposed to multiple training programs. The only thing that's disappointing about these kinds of studies is that we have found that in the environment that we regulate that way, we get marked improvements in ADHD symptoms. But there's no generalization to the non-training environment. There's nothing that endures when you stop the training program. And that's been the downside of these programs. And we're trying to solve that through how do we program for generalization? How do we get the skill to endure? We haven't quite worked that out yet, but it suggests that might be possible. And if you were at my 4 o'clock talk, you know that I did make an argument for, with teenagers, moving more into vocational training in addition to academic training of these individuals in order to help make them better prepared to enter the workforce than they currently are. I don't know that that needs to be done in so intensive environment. Sheltered workshops, I think simple vocational technical schools suffice to provide that. But I think the mindset you're talking about is a very important one, and that is much more environmental regulation to a more intensive degree, earlier and longer over time. Because what we're learning is we have interventions that work, but if they're limited to childhood, they make no difference by adulthood, and they don't carry over into untreated environments that we didn't pay attention to. But I think those problems are potentially solvable.
I know you have a new book out on adult ADHD.
Yeah, it's not for the faint of heart, let me warn you.
But is the information you were covering this evening and at the 4 o'clock session, is it contained in that book?
The information at the 4 o'clock session is in the new book. Now, I want to make sure, because I don't want to mislead people, my new book is a scholarly science book. And although it is written for clinicians and professionals to read, it certainly is not a trade book. It's not Ned Hallowell's Driven to Distraction. I mean, people who do science will appreciate it because I think it's probably the most definitive statement putting adult ADHD on the map as a legitimate adult disorder. But if you're obviously educated, well-read, you would be able to go to that book. But I tell people to use it more as sort of a desk reference. Open it to the chapter on workplace problems. Open it to the chapter on early sexual activity, driving, and so forth. It's not meant to be a continuous bedtime read. It's hardly a Gresham novel by any means. So I want to make clear what it is and what it isn't. But certainly that's where all of the results, including the new results I didn't talk about tonight on clinic-referred adults with ADHD, it's all in there. Now, as far as what you saw here, you would have to look at my handbook for diagnosis, combined with Joel Nigg's recent book on the causes of ADHD, to really begin to pick this up. And then some of these are studies that were published just within the last few weeks to few months, and those are not in any book at this point in time. So, yes, thank you. We have a friend in common. So,
you said that video gaming isn't a cause for ADHD,
No.
but does it influence the severity of it over time?
Rosemary Tannick and, in Canada and Steve Houghton in Perth, Australia, have looked at video game playing in ADHD children. And what they found, of course, is what parents find. An ADHD child will sustain their attention to a video game longer than they will to something that's not computer-generated or computer-delivered. So in that sense, yeah, they play those games longer than they do their homework. But what they found is if you look at the way they play the game and what they're doing during the game, first of all, they tend to play it more solitary, whereas most children play video games with friends, and groups. And ADHD children are a little more solitary, but that may have to do with their social rejection. The second thing is you see the executive deficits. The more the video game demands a lot of management, organization, strategy over time, you find the ADHD child can't compete with a normal child in the executive aspects of video gaming. So as Rosemary pointed out, they play video games better than they do other things. They are not normal in the way they approach gaming, and gaming doesn't make them normal either. But it certainly doesn't contribute to their ADHD, as some people have argued, that TV and video game playing are a cause of ADHD. And instead, I think they got the chicken and the egg reversed. People with ADHD are more likely to watch television, are more likely to play video games. They're also more likely to talk on the cell phone and not read for pleasure. But that doesn't make those things causes of ADHD. Those are the things that people with ADHD gravitate toward when they're given choices in their leisure time activities. Okay.
Hi, I'm not a clinician or a professional. I'm a member of the community.
Yes.
But in my home, I was very taken with the part about the genetics because my husband is 71. 2 years ago, he was diagnosed with Asperger's syndrome, which he's had, of course, all his life. I have a son that's compulsive obsessive.
Yes.
I have 2 grandsons with ADHD. My husband, through the years, was diagnosed with alcoholism, with ADHD, anxiety disorder, and yet he had a good professional life in filming TV series.
Good.
So, to me, these things are invisible to a lot of people when someone's successful.
Especially in very bright, intelligent, accomplished people who have resources. The head of JetBlue, for instance, claims to be an adult with ADHD. But I certainly wouldn't want to hold that up and say there's a benefit to these disorders. I think what you're seeing is that some people, particularly very intelligent people with resources, find ways to compensate and self-select into certain occupations that make them less impaired.
Right. And what I noticed and what I got out of this tonight so much, and I want to thank you for it, is the genetic connection. Because my husband's siblings have Asperger's, his father had Asperger's, we believe, and I'm looking at my children now, my grandchildren, and my child, 1 or 2 of my children. I love the statistics about if the father has it, how many children do. Although I'm not a professional, I learned a lot.
Good. Thank you very much. I tried to make it accessible to the public as well as professionals.
Okay. Just in regard to the SCT population, do you see similar deficits in executive function with those? It is different. It is really
if
distinct.
you looked at the bottom of the slide, and I went by it very quickly, there are some recent studies, particularly a very nice one by Mary Salanto, that shows that the executive deficits we see in ADHD are not typical of the SCT inattentive-only kids.
And then in your earlier talk, in regard to adult outcomes, is it different for those SCT individuals?
There are no follow-up studies of SCT. I said that right at the beginning of that talk. I know I glossed over it very glibly, very quickly, but we don't know what SCT children look like over time. So everything I talked about this afternoon on life course outcomes is combined type ADHD. Okay. Julie, one more, shall we? Sorry, they're holding up a dinner for us, that's all.
I was fascinated by the observation about the motor strip in the early development, and then the lagging of other parts.
The executive aspects.
So therefore you're having these two things. You're having this accelerated motor drive and your behavior.
Coupled with the lack of a brake system.
Yeah, exactly. So you've got high RPMs and no brakes. And
isn't that fascinating?
Yeah,
I mean, that's just where research is going, neuroimaging studies in particular.
That explains a lot of things. It's very interesting for how long it goes to and how that comes together.
I want to thank everybody for coming out.
Yes, good night, everyone. Thanks so much.
The UC Davis Mind Institute began in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, learning disabilities, and other brain disorders is helping children achieve their fullest potential. Please call or visit our website to find out more about current studies, our research team, and upcoming events.